So with that being said, let's get to the first round of questions. We'll begin with Ms. Goodridge. You have the floor for 6 minutes.
Thank you, Mr. Chair. It's wonderful to see you in that spot. Thank you to all the witnesses for making time to be here today as we study this really important topic. I'm going to start out, my first question is for you, Dr. Serida. New information has recently been released that corroborates previous reporting that there's mass safe supply diversion happening near the Chapman's Pharmacy close to your clinic. Are you aware of this diversion near Chapman's Pharmacy?
A question for you as well, Ms. Goodridge. What evidence has been released showing this?
It was in a series of tweets from one of the journalists, Adam Zivo, and it was put out already today.
Okay. So, I mean, safe supply clinicians, we rely on good research and published evidence and not on anecdotes and tweets on the platform of social media, Twitter X.
Okay, thank you. So are you aware?
Excuse me, Ms. Goodridge, if she had more, we'll give her another 20 seconds, please.
And so Mr. Zivo is a columnist for the National Post who has dipped his toes into this for the past 8 or 9 months. And he certainly, you know, early in his writing about safe supply expressed his desire to burn the whole system down. So I'm not sure that he's a terribly credible source of information that we want to rely on in this committee. In addition, Mr. Zivo has visited Intercommunity Health Center, where he was actually a very bullying presence to my patients. There is a gate just outside my clinic door that is 3 feet from my clinic door. I'm not finished, Ms. Goodridge.
It doesn't really matter whether you're finished
Mr. Zivo
or not.
blocked access to health care through
I'm
the
sorry,
only
Dr.
door to my
Sereda, I
clinic.
think I made you aware very clear of the convention we have in this committee. I really request that you respect that. I've done that with respect to Ms. Goodridge. So again, let's be respectful today, everyone. Thank you.
Does diversion of safe supply worry you?
I think more important than diversion is the discourse around the diversion that's happening in the media. And so diversion is it is complicated, and it requires more than a 60-second answer if I can finish.
I appreciate that. I have a very limited amount of time, so I asked really quick, simple questions and wanted simple, quick answers. BC's recently developed some protocols that allow for recreational fentanyl to be prescribed to children in the guise of safe supply. What are your thoughts on this?
I think the BC CSU has very carefully consulted experts, both in who provides addiction care, harm reduction care, and the care of children with substance use disorders. And so I'm not aware that any children have accessed this protocol to date. But if you read the protocol, it is the same as any other kind of complicated health care for children in Canada, whereas 2 experts need to agree. The person needs to be carefully assessed for the risk and any benefit of treatment. And in some children who are dependent on the toxic, illicit fentanyl street supply, physicians who are caring for them can make expert decisions in what they need for their health care.
So do you think that we should prescribe recreational fentanyl to children?
I think if children are at risk of dying from the toxic street supply, which we know over 90% of deaths in youth are from, which is illicit fentanyl.
Thank you. I'm going to turn that over to Dr. Rob Tanguay. I'm wondering if you could perhaps expand on this. What are your thoughts when it comes to prescribed recreational fentanyl to children, as been suggested by British Columbia?
Well, I'm in a belief of focusing on treatment and a process of such. I think at the end of the day, the prescription of recreational substances to anyone without a diagnosis and a treatment algorithm can be problematic. And there's really no research or evidence or peer-reviewed literature to suggest otherwise. That being said, if it's a molecule and it stabilizes someone and it's in a guise of helping someone recover from severe addiction, then I'm all for whatever that molecule may be. It comes down to whether we're focused on treatment and what that algorithm may look like.
Thank you. One of the big questions that we've been facing as we've been looking at this is the idea between what does treatment look like, and I'm just wondering if you could describe some of how you approach addiction medicine and treatment, and how that can look in your practice.